Welcome to slide presentation of systematic approach of chest radiograph interpretation. Reading chest radiograph requires a systematic approach. Failure to be systematic can lead to missing pathology or over-reporting, which may lead to inaccurate or misleading conclusions. There is not just one technique to examine a chest radiograph. Every doctor should develop his or her own technique, but the technique must be comprehensive. Check the patient's details including name and date of birth. This may sound pedantic, but it's very crucial to avoid reading film of a wrong patient. Noting the age is also important, as we know that certain diseases are more common in certain age groups. Having checked that it is the correct patient, check the date of the film to ascertain which one you are viewing. Check the orientation, position, and side description of the radiograph. Most chest radiographs are of posterior anterior or PA projection. The usual indication for anterior posterior or AP projection is for a patient who is confined to bed. The heart looks bigger on the AP view. The normal position is erect. Supine is usually for patients confined to bed. In a supine film, blood will flow more to the apices of the lungs than when compared to the erect film. Failure to appreciate this will lead to a misdiagnosis of pulmonary venous congestion. After you have checked that it is the right film for the right patient, it is important to identify whether or not the radiograph is technically adequate. Without this crucial step, you may diagnose disease that is not genuine. If the image is not of best quality but the clinical question can still be answered, a chest radiograph need not be repeated. The chest radiograph should be checked for rotation, inspiration, penetration, and inclusion. The module or tutorial on image quality of chest radiographs covers this in more detail. Check both lungs for any abnormalities, including infiltrates, nodules, masses, collapse, or pneumothoraces. Check the volume of the lungs and compare both sides. Each lung is generally divided into upper, mid, and lower zones. It is useful to focus on each zone one by one and compare with the contralateral side when reviewing the lung. Check the heart size and heart borders. 1/3 of the heart should be on the right and 2/3 of the heart should be on the left side of the spine. The margin of the left atrial appendage should be slightly concave. Straighten or convex margin of a left atrial appendage alongside with widening of the carina and double right heart shadow may be seen in case of left atrial enlargement. Check for any pericardial calcification. Check for any thin rim of air around the heart, which may indicate pneumomediastinum. Check at the region of the heart valves for calcification or evidence of valve replacements. Check the aorta for any widening, tortuosity, or calcification. Check the size and position of both hilar. Enlarged hilar may be caused by hilar lymphadenopathy, perihilar lung mass, or enlarged pulmonary artery. Enlarged pulmonary arteries in case of pulmonary hypertension are usually bilateral and demonstrate hilar convergence sign. Check for hilar angles. Check for any calcified hilar nodes. Check for widened mediastinum, which may be caused by mass lesions, aneurysm, or major mediastinal vessels or mediastinal hematoma. Check the pleura for any thickening, calcification, effusion or pleural-based mass. Observe the diaphragms. The right hemidiaphragm should be higher than the left. If much higher, think of subpulmonic effusion, lobar collapse, or diaphragmatic paralysis. On an erect film, one may see free air under the diaphragm if intra-abdominal perforation is present. Check the included bones for fractures, dislocation, or osteoblastic or osteolytic lesions. Check the shoulder joints and spine for osteoarthritic changes. Check the soft tissues for subcutaneous air, foreign bodies, and surgical clips. There are a few areas on a chest radiograph that need extra attention, as subtle changes may be overlooked if these areas are not being scrutinized properly. These areas are known as blind spots or review areas. They include lung epiphysis, hilar, retrocardiac regions, costophrenic angles, subdiaphragmatic regions, bones, soft tissues, and edges of the radiograph. Thank you.